Hi, Steve Small here. Welcome to another episode of the Spinal Decompression Show, where I am thrilled to be joined by Lawrence Bergstrom. Lawrence is an osteopath and he is the clinic director of Swale Back Pain Clinic in sunny, I think, Faversham in the Garden of England, Kent. Lawrence has been an osteopath for 20 years or so, and absolutely thrilled to have Lawrence here today to talk about a few things. Lawrence, good morning. How are you today?
Hey Steve, good morning. Yeah, you're right. It is a sunny morning here in Faversham, and I hope it is with you too. Yeah, great. Ready to go, and hopefully we can add a few interesting insights into this podcast for you.
Yeah, I think Lawrence has been providing IDD therapy for about 3 years now, and we often chat and discuss things. And a topic came up um, in my own experience earlier this year. I had a nasty disc problem, and in one of the sessions, I noticed that the nerve in the offending leg was twitching really violently, more violently, excitedly during an IDD therapy session. And Lawrence very kindly left me sent me an explanation about this process of fasciculation. And I thought, it was really interesting, and I thought actually this opens up a really nice topic. So that's kind of what we're going to be wanting to go through a little bit today. But to start with, Lawrence, tell people a little bit about yourself, what you do, and how we've come to be here today.
Yeah, sure. Thanks, Steve. Well, as you said, I've been an osteopath for over 20 years now, and predominantly treating the majority of our patients have been spinal pain patients. Um, yeah, during that time, we've been seeing a lot of disc injuries, in particular, facet joint problems, a lot of sciatica, and so on. And the majority of those patients we treat successfully with manual therapy, with exercise, lifestyle advice. But we have about 10% of our patients each year, which they're a real challenge. They've seen pretty much everybody. So by the time they come to see us, we're often their sort of last line of defense. And we'll go on to talk more, of course, about the role of decompression therapy within their care. But so yeah, we're a very, very busy clinic in Faversham. I had a background, I was in the NHS for 10 years, and that was a great environment because there was a huge amount of experience to be gained there, working in a multidisciplinary team. So I've retracted from the NHS now, and full-time private practice was so busy that, I've stepped away from the rigors of the NHS. But yeah, and prior to that, I was involved in elite level sports as a competitor and then went on to work in that realm as well.
Fantastic. And I think you had a back problem yourself, I understand. So that gives you a sort of a real empathy with your patients. I mean, what sort of pain did you have, or what happened with you?
Yeah, I did. I went from elite level fit to disabled. And with the knowledge that I have these days, I now know that it was a severe L5S1 disc prolapse.
Right.
But at the time, it was a very isolating, very worrying, very frightening time. I was in agony.
Yeah.
I was in a situation where I could stand in a great deal of pain, or I could lie down. I couldn't sit at all for over 9 months, not even for 10 seconds. I couldn't work. I couldn't really walk. I was living downstairs and I was literally getting rinsed at the kitchen sink.
Mm.
Yeah, it was awful. And I went right through the NHS journey and indeed into the private sector as well.
Mm.
And interestingly, if you believe in fate, or if you believe that, things are sent to guide us or to test us in some way, the one person that could diagnose the problem after I had exhausted my journey through the NHS and seen numerous private practitioners, one guy diagnosed me on the spot. His name was Frank Westall. He was an osteopath. He'd worked at the Olympics. He'd worked with, he was a bit of an osteopath to the stars, really. I think he treated the Rolling Stones, you name it.
Wow.
But yeah, I mean, I walked into his office. He diagnosed it. I thought it was a charlatan at first because he was so immediate in his diagnosis. And he
Mm.
said it's going to be 6 months before you're anything like moving reasonably well. It's
Mm.
going to be 12 months to 18 months before you're starting to feel you're getting your health back. And he was dead right. So it was a very tough 2 years. But this
Were you having regular treatments with him, or was he just kind of
I
self-care?
was.
Yeah.
Yeah, no, I was. Yeah, I was seeing him a couple of times a week. And because of my location, I mean, I was recommended to him, but I was living in Kent and he
Mm.
was in Palmer's Green in London. So
Right.
you
Right.
can appreciate when you're in that much pain, you know, it's almost like somebody saying, just commute to Australia for your treatment. You know, it was hellish,
Yeah.
but it was a hell of an experience. And during my time with Frank, he actually became a little bit of a mentor for me,
Mm.
and we had many a conversation. And I became quite inspired by his work and his
Mm.
knowledge and his expertise. And I thought this is a journey I'd like to undertake. So then it was a long route through training, and here we are today.
I see. That's a nice, interesting. And where did you train, Lawrence?
London School of Osteopathy.
Okay. Okay. That's now the university.
Yeah, part of, yeah.
Okay. And how was that? Did that go well?
Yeah, I
Interesting.
mean the training was tough. The
Mm.
training was tough, you know, and yeah, 5 years, 5 years. But yeah, I mean, again, it was very humbling, very challenging, and you know, they said at the time, you don't do osteopathy, you become an osteopath, and you know, at the time, I thought, well, I'm not quite sure what they mean by that, but you really do, you know, and you're seeing people from all walks of life, and of course, it's with osteopathy as well. It's musculoskeletal, so we're treating peripheral joints as well, and of course, they are relevant to the spine. You know, if you have a foot or ankle problem, part of the kinetic chain, of course. So if you don't resolve that, then the spine's going to suffer anyway. But yeah, it was a great education, and yeah, I'm delighted that I put myself through it all these years later.
So fast forward, and
Mm,
you were practicing. I think when we met, you were practicing. Obviously as an osteopath in Faversham,
correct.
and you started to hear about this, IDD therapy,
Mm.
and you elected to bring that into your clinic. What sort of patients? Are you seeing now with the IDD, and how has that, how has that been for you?
Okay, well, I mean, this will interest you. Just a little sidebar or an anecdote, if I
Mm.
may. When I
Mm.
was an undergrad, you know, we were neophyte greenhorn osteopathy students. We didn't know anything about anything.
Mm.
And a question in a lecture was given to us in a biomechanics lecture, which was, could anything be applied, excuse me, could anything be applied to the human spine mechanically that could bring about some form of, you know, efficacious result, you know, some form of therapy? And of course, as highly informed, you know, neophyte students, we went, don't know. Well, you know, here we are all these years later with very specialist equipment, which is quite literally applied to the spine. So,
Mm.
um, 10%, 8 to 10% of our patients, we've had to refer on to orthopedics or onto neurology. And it's always a painful conversation when the patient comes to you that put a lot of faith, a lot of trust, and of course, privately, a lot of money into their care as well. And similarly, when I was in the NHS, you know, the patients were referred to me via their GP. And when you have to sit there and say, I'm so sorry, there is nothing more I can do to help you, it's heartbreaking all round.
Mm.
And, you know, and if you're in this business to help people, you go home feeling beaten, you know, even if people say, well, you've done the best that you could with the skill set that you have, you still feel beaten, you know. And my past background is, you know, I'm very competitive by nature, so I don't like being beaten. Um, you know, you and I mean, you reached out to me, and decompression therapy was in the back of my mind. I knew it existed, but in the same way that in the musculoskeletal realm, laser was all the rage for a while.
Mm.
And all my colleagues were rushing out to do laser courses and invest in an awful lot of equipment and, you know, goggles and so on. And I thought, well, let's just see. So similarly with decompression and IDD, I thought, well, let's see. I'm not going to rush out and invest in this. Let's see if it holds water. And then, of course, as time went on, you started to see more and more people were talking about this and saying, this has helped me where everything else has failed.
Mm.
And it was around that time, you know, it was in the back of my mind, and you kindly reached out to me. And then you reminded me that when you went back through the email trail, we'd had pretty much a 2-year conversation. And then, you know, the penultimate conversation was, Lawrence, I think I've exhausted every single one of your questions. Either you take a deep breath and jump in now, or maybe this just isn't for you. And I thought, well, let's do it. And I'm delighted to say that after the trepidation, you know, there's the investment, there's the, you know, the training, which thank you is excellent. And then you're now thinking, wow, we're stepping up here. We're taking on serious spinal injuries. You know,
were you daunted? Were you daunted by that?
Excited and a little daunted. I think anybody that isn't is a bit reckless, to be honest, because you are now putting yourself in the frame where you have patients coming through the door and saying, I've seen an orthopedic consultant, I've seen my GP, I've seen a neurologist, I've had injections, I may be facing surgery, or there isn't a surgical target, or I don't want surgery. And I always say to my team that, and anybody that I speak to, that disc patients come in twos, the sufferer and at least one concerned family member or friend. So that, you know, that comes with a certain amount of pressure, because they're coming into your consulting room, they're looking for help, they're also very doubtful. And, you know, they're, well, is this snake oil? You know, is this a very expensive gimmick, only to find out at the end of the day nothing helps and I've lost even more money? And you and I touched on a conversation before about this, that often by the time people come for the treatment that we provide, the care that we provide, they're understandably suspicious, because they've exhausted the NHS route. They've now spent hundreds or thousands, and then they're in a position where we're then saying, well, you know, we can really help you, but there's a fairly significant you know, investment in that care. But when we see the turnaround, you know, some of the revelations we've had are just phenomenal. I mean, we're consistently seeing in 92% of our patients either significant improvement or complete resolution of their pain. And we do have many success stories where people have gone from not working for 3-4 years back to work, back to driving, booking holidays. And something that, without wishing to, and I think this is relevant, I think this is fair to share in this, we have patients on occasion that will sit there and candidly they will say, we've had patients, and I'm not sharing this for melodrama, this is 100% true. We've had patients that have said, look, I've been thinking our kids are off our hands, my wife will be okay, the house is bought and paid for. If this doesn't work, that's it. And when that same person is coming in 3-4 months later saying, we've booked a holiday to New York.
Wow.
And you're thinking, only 4 months ago, you were talking about ending your life because you were suffering.
Yeah.
So I'll be honest with you, was I prepared for that right at the start?
Yeah.
No.
Yeah.
I, you know, very much. I thought, well, if we get patients coming in saying, you know, my back's feeling better, I can move better, my sciatica's improving, I was thinking, great job. But as a consequence of this, over the past few years, and this is something that I discuss with my team regularly, and interestingly, my team have suffered as well. Molly, she's superb. She's my technician, my IDD technician and rehabilitation therapist, and she's had severe sciatica, and she's an elite runner.
Right.
Glenn, our ops manager, you know, he's had severe disc injuries. So we understand this personally. And, you know, when patients are coming in agony, you know, I say to my team that, you know, we're not treating discs per se, we're treating people with significant injuries. So we need to come at this from how they view the world and their injury first. And that's where education is so important.
Yeah. Well, I mean that's it's pretty profound,
Mm.
and I suppose that gives you a good sense of mission and sort of value for what you're doing. Um, Perhaps we could sort of talk a little bit about, just in terms of the how you're managing patients
Mm.
with IDD,
Sure.
and like you say, you have people who haven't worked, they're coming in for the program. We, in IDD, we use tensions, and I sort of wondered
Mm.
how you
Mm.
use the decompression tensions. How do you typically evolve a patient's treatment program with your
Okay,
IDD?
sure. Well, diagnosis is key. Diagnosis is everything. So the plan, we arrive at the treatment plan through a very specific process. So it starts with the narrative. So number one, we must listen very carefully to what the patient's telling us. And about 80% of the diagnosis is in the narrative. So we take a full medical case history.
Mm,
From that, we then progress to a comprehensive physical examination, which combines orthopedic testing, neurological testing, and osteopathic assessment.
mm,
Um, if they've had an MRI within the last 12 months, then we will review the images and their report. If they haven't, then we're going to refer them on first. And the reason being that we need to assess very, very clearly the most likely cause of their symptoms. Now, a huge amount can be gained from the narrative and the examination, but we want to get those medical ducks in a row, because if we've got the history, the examination, the findings of the examination, the patient's narrative, and we've got evidence on MRI, we're in a really good place. And our experience is pull all of those together and we get very, very good results. Now, there is scientifically, there's talk that MRI, and I see this with patients, and some patients are very informed. They say, yeah, but MRI doesn't actually really tell you where the pain is, just because there is evidence of change in the spine. But
mm,
there are those occasions when it's more complex than that, but invariably we're finding if we follow that system, we get great success.
mm.
And then we look at category 1, category 2, category 3 disc injuries. So one disc can have maybe 4 or 5 injuries. So some patients will come in and they'll have multiple level changes, but within that, invariably, there's a primary causation. So let's say they have changes, they might have dehydration and bulging at L2, L3. They might have a fresh annular tear and a greater level of bulging at L4,
Mm.
and then some change at L5. Our job is to decide which of those is most likely to be indicative of causing their pain. Now, one of the beautiful things with decompression therapy and IDD is we can test levels.
Yeah.
So that gives us a really useful tool, so we can be confident when we're talking to our patients. Say, look, you've got multiple changes here. First, to gain your confidence, you need to feel that you're starting to feel improvement. Now, we're going to target a specific level first, but we're not just going to give you a number of sessions. If it doesn't work, oh well, sorry, we've taken your money, goodbye. We're tenacious, we work hard for our patients. So then we can test specific levels. And within that, we have different oscillation, of course. So depending on how acute they are,
Mm.
if, for example, they're very acute, we tend to use a low oscillation.
Yeah.
If they're really, really acute, their high tension will tend to be half body weight minus 25 pounds. But on average, what we're finding, and Molly and I talk about this a great deal, that we actually now push, with the experience that we've gained over the last few years, we
Mm.
actually push harder than we used to. We used to be very tentative and say, oh, gently, gently, gently. Then you look further down the line and you think, we could have probably pushed harder during
What,
that first 10
what,
sessions.
when you say push harder, so for
Mm,
people, so typically with IDD, the treatment tensions are a function of half body weight, and the starting tension is perhaps a half body weight minus 20 pounds.
sure.
And obviously there's some considerations there. So one of the things is the increasing the distraction forces. So
Yes.
there, when you're saying with experience you're pushing harder, is that sort of increasing the poundage, the pull quicker?
Yes, yeah, exactly that, Steve. Yeah,
Mm,
we're we'll go up in 3 or 5 pound increments quite quickly,
yes.
and this is entirely dependent on the patient's reaction. So
Yeah.
we explain to everybody. We joke, but we're serious when we say sounds a bit mean, but we expect you to get a bit sore.
Yeah.
And we talk about, I mean, you go to the gym, I go to the gym. We talk about DOMs. Well, I've nicknamed something called DOTS.
Dots.
So
Okay.
DOMs for the uninitiated, delayed onset muscle soreness after a good workout in the gym.
Yeah.
Well, for me, DOTS is delayed onset tissue soreness because, of course,
Okay.
yeah, when we're using those pulling forces, those high tensions through that segment,
Yeah.
we have disc adaptation, we have ligamentous adaptation, we have joint capsule adaptation, we have soft tissue, we have fascia, we have muscle, we have nerve, we'll come on to fasciculation. So
Mm,
there's a lot changing there. So we do say to people, you will feel some soreness. Now, some of our patients absolutely cruise through their treatment. At no point when we say, "Were you sore after your last treatment?" No. How are your symptoms? Getting better.
mm.
So we don't push them to the point, "Oh, we really want you to be sore." That's sadistic.
Yay.
Yeah. I mean, on that note, a lot of our patients, they affectionately nickname our machine the rack. But
Mm,
thankfully, this is therapeutic and not sadistic.
yes.
Um, but then there are other patients. I mean, the beauty of the acuspiner in particular is its versatility. If somebody's, I mean, some people, their morphology, they're very sort of slight in their morphology, but they can receive quite a significant high tension, and then you can have the reverse of that. But our general experience is the more robust the patient,
Yeah.
generally speaking, they can receive a stronger higher tension, but it is very much dependent on what's happening to those tissues. If somebody's got a very acute disc, you don't want to be pulling that too hard too soon.
I remember when I first started my IDD therapy early this year, and I was in a
Mm,
very bad way. And
yes.
my starting tension, and whenever I've gone on IDD, I have a starting tension of half body weight minus 20 pounds, which in my case is about 80 pounds.
Mm,
And I couldn't actually imagine it going up to an over half body weight. And then with the treatment, I was like, I was like, oh, okay, yeah, I'm fine. I'm asleep, and these tensions are increasing. And then
mm,
you go above half body weight, and you are you're feeling fine. And I have heard that from a few clinics where, that there
mm.
is as I said, that slight trepidation when we're starting, which is fine. And then as your
Yes.
confidence and as you see the outcomes and how people change, then yeah, you're maybe increasing things. Just can I just come back to a point you made,
Mm,
Lawrence? So typically, when we're treating a specific segment, we have a target angle, shall we say? And you spoke
mm.
about somebody with multiple levels and
Yes.
how you might adjust things because we can't be sure. It's not diagnosis by MRI. So do you start by you're looking in terms of your assessment. The scan is helping you to confirm that the symptoms that you're seeing, and that's the
Yes.
level that you treat. How long would you go before you maybe would think about changing the angle, or when would you change the angle?
Okay, no, that's a great question. I mean, generally speaking, we would, I mean, a ballpark figure. I mean,
Mm,
we have sort of four categories. So if a patient comes to us and they have a presentation which suggests we can help them, but we can't be quite so sure,
mm,
we offer them an 18 session trial.
mm,
Now, around session 12 to 13, we need to be seeing solid evidence of improvement.
mm.
Now, if that's the case, depending on their journey, depending on how they're improving, we'll then sit down and have a conversation. We'll review them, and certainly at the end of the 18 sessions, we'll then discuss: do we feel there's sufficient efficacy to warrant continuing, and if so, how many more sessions? Now, a category 1 disc is typically 24 sessions for us.
Mm.
So around session 5, session 6, we want to see that they're certainly comfortable. And because we push relatively hard now, as long as they're saying, well, I'm improving in mobility a little bit, we're not expecting at session 5 or 6 their problems resolved.
Yeah.
Although we do get, interestingly, with some severe sciatic patients, within 2 or 3 sessions, they're already saying they're feeling improvement.
Yeah.
But with disc particularly within 5 or 6 sessions, we expect people to say, got out of bed a little easier. I could even think about getting my socks on, these kinds of things. If that's the case, we'll tend to stay where we are. If there's no improvement whatsoever, we will then, if we've got a couple of levels there that, say 2 levels that both suggest there's a significant issue, we'll move at an early stage. That we used to do it later, and then we'd find out, perhaps, say in a 24 session plan, we were then 8 sessions from the end, and we'd say, well, let's change angle, let's change disc level, and then they start to improve. We then thought maybe we should have done that at an earlier stage. So typically within the first 5 to 6 sessions, people should be saying, at least I'm a little bit more mobile, or there need to be what I call green shoots of improvement. It's not going to be miraculous, generally speaking, but we have had, and I mean, we talk a lot about placebo in the clinic, and we've had patients that they've limped in, they've practically been on their hands and knees, and you and I have both been there. We know what that's like, and and after one session, they come back and you say, how are you? And say, yeah, a little bit better. And even to the point where I, on occasion, that, you can't be, you've only had one session. But we don't talk a patient out of that, because if they're feeling a bit better, they're feeling a bit better,
I mean, it is interesting. I mean, it's a large, the question of placebo, and that sometimes people say that, and I think when you've experienced it yourself, it'd be a little bit like saying, if you went to the gym and lifted some weights, the soreness or that's all a placebo because you saw some metal. Now, there may well be. I think there's definitely a psychological component to people feeling, actually, there's something significant here that is different from my typical rehab that I have been doing, and I'm not discounting that, but you just kind of there's something very physiological sort of happening. So that's that's interesting that changing the angle, and I know with myself, changing the angle even by 5 degrees, you can get quite a different sort of feeling. So you're progressing the tensions and perhaps pushing it on. Do you sometimes ever have to rein back the tension? It's gone a little bit too far. That DOTS is a little bit severe.
Yeah, absolutely. I mean, we explain to all our patients that
that's going to be called the Bergstrom DOTS thing. I think.
Oh, right.
Yeah, I've heard that before. So
that's it. We'll copyright.
That's yours. That's yours. Yeah.
That's my contribution to medical science. There we are. I can end now. I can finish. So you're quite right. I mean, we explain to patients that, because we do boot camp some patients. And what do I mean by that? Some patients, and there's a growing body of evidence to suggest that more intensive treatment for certain problems, particularly say dry discs. Wet discs tend to respond a little bit more readily, but drier discs can be slow because the physiological pump in the disc is so diminished. The disc's ability to draw in water, to imbibe fluids, oxygen, nutrients, to detox the disc, get that physiological pump going, is slow. So if we boot camp a patient, we might treat them twice a day, and a lot of people are quite shocked when they say, so will I come once a week? And you say, no, you're going to come in sort of maybe 10 times this week,
Wow.
And they're like, what? But it works, so wow. if the disc is really dry and we think this is going to take forever, and they're amenable, and we have some residential patients now that they're out of area, but they're learning about the successes we're having, and we're delighted and honoured that they want to work with us because they know someone or have read about somebody that we've had a great success with. And so what they'll do is they'll stay next door to our clinic at the hotel. We'll treat them first thing in the morning. We'll treat them later in the day, and then the rest of the day is gentle rehab, icing, resting, a little bit of movement. So that can work really well.
I mean, I've heard that when I first started, and I heard of somebody who they were going to have to get on a plane. They had to get on a plane in a week's time,
Yes.
and they had treatment twice a day. And you think, wow, that's very intense. And they got on the plane, and so that's a sort of interesting. I think if we may, I think the interesting thing with IDD is any topic can open a can of worms, and we can go down that and I guess what you've just been describing is as you've used it, you've learned so much and sort of, I guess, grown in understanding of how these patients are responding and adapting, which is great for them. I think where we sort of started, and perhaps it'd be interesting just to delve a little bit into the reaction of patients. So when I was having having an IDD session, and I found, and I've got an L3 L4 disc prolapse, and the leg, pain in my right leg was horrendous. And then on the IDD, I started to notice during the sessions that the nerve in my thigh was twitching, and you kindly taught me the term fasciculation. And this happened a few times, and one time I even tried to record it because I just thought this nerve was bouncing out of my thigh. It was like, oh my gosh, too much out. What's your experience then with patients with these sort of prolapse discs and nerve pain? What's actually happening then with this fasciculation? What's happening to nerves, and what sort of journey do people have with their nerve pain?
Okay, thank you. Well, the fasciculation, everybody will be aware of, even though they won't have heard the word. And just about everybody at some point will have had a twitch under their eye or in their cheek at some point. And it's called a fasciculation. It's a manifestation of a lower motor neuron. Now, the fasciculation under your eye, for example, in your cheek, is hyperexcitability of a motor unit. So something has irritated the nerve sufficiently to hyperstimulate the tissues that nerve supplies. Now, one of the things that we talk to our patients a lot about is we use the word activity. Now, if we sort of go from two extremes, so the one extreme, if you like, is the healthy extreme, that you're not even aware of your nerves. Your limbs are behaving as they should do. You don't think about it. It's completely unconscious. Now, if we go to the other extreme of severe nerve compression or nerve death, if you like, as extreme as that sounds, you're definitely you'll be aware. Now, it could be a loss of motor function, so there's total weakness, or it could be partial numbness, total numbness, as one of our patients quoted once, and I borrow her quote often when I was asking her about her nerve pain, and she pointed to a region of her thigh, Steve, and she said, "You could stab this to death all day long and I wouldn't feel it." Right. So that's a pretty good example of, but it's just that area of her thigh was completely dead. Now, there's a middle ground to be had as well. So the typical behavior of nerves will be things like shooting pain, numbness, tingling, altered sensation, the feeling of ants crawling. People often say if it's their leg, for example, or their thigh, they'll feel like they've sat in cold water. Now, what happens is, and you only need 0.5 of a millimeter of contact on the epineurium, the sausage skin of the nerve, for long enough for it to start to change the function in the nerve. So it was described to me as by a neurologist as a fly landing on the nerve. Now, he also said, when you think how sensitive nerves are, and that something as huge as a horse can feel a fly land on it.
Mm,
So when you think about our nerve tissue, it's so delicate. So by the time you get anything that contacts that, it could be a cyst, it could be calcified ligament, it could be a bony osteophyte, it could, often in our cases, it's bulging disc material.
mm,
Now, the analogy that we give to our patients is, if you imagine the joints in my finger to be the gap junctions along the axon of the nerve. Nerves are very, very long. Now, ordinarily, nerve function is lightning fast. It's absolutely, it's lightning fast. And it's two-way. So there's two-way trafficking, and you have neuropeptides and mediators that run up and down the nerve, which then allow for the electrical impulse energy to move along these junctions at, lightning speed. Now, all you need is a tiny bit of compression on the outer part of that nerve, and it causes friction. So in essence, it slows the electrical impulse energy down just a fraction. And that's enough for you to register it. And that's why you then start to think, I've got tingling in my foot, or I'm getting, sort of trickling feelings down the outside of my thigh.
mm.
Now, for peripheral nerves, they're mixed nerves. So they provide motor power. They provide, excuse me, I talk too much.
No, no, it's good.
They provide sensation, motor power, and sensation is a broad church, so there can be things like pricking, shooting, burning. I mean, I don't know if you're aware, but there are over 204 commonly used descriptors of pain.
Wow.
So it's a very experiential personal journey as well. But the fasciculation that you experienced in your thigh is where you're getting hyperexcitability of the nerve. And the other area that people will be aware of is the ulnar nerve, the funny bone.
Yeah.
When you bash that for a split second, and the ulnar nerve sits in this groove between two bones in the elbow, and then it passes through the flexors of the forearm, and then it supplies muscle power and sensation to this part of the hand. Now you hit that for a split second, and you really shake your hand out. You feel it for a little while.
Ow.
Yeah. Now, if you imagine that you've got something just a mild amount of pressure on that nerve, it's not going to be long before you've got continually altered sensations.
Mm.
Now, when someone's on the AccuSpine or on the IDD table, and they say, I'm getting shooting pains, I've got numbness, I've got, tingling, we say it'll probably increase when you're on the table.
Okay.
It could increase or it could decrease. Now, patients will sometimes say, as they go through their journey and they improve, they say, I think we should perhaps stop now. And you say, okay, why? And they say, well, the only time I get tingling is when I'm on the table now. And you say, okay, well, that's good. And they say, well, how is that good? And they say, well, if you think each time you decompress the disc, it's a one-time event, during that day, that disc material, until it's come away from the nerve sufficiently and the nerve has had enough time to recover, we're still getting elements of friction in the nerve. Now, when you had that fasciculation, that hyperexcitability was, if you like, the nerve is waking up. The other analogy I give to patients is, if we've all had frozen hands at some point. Yeah, your fingers are frozen, and you got your hands under your armpits, and you sat there, and and then you get to the point, the midway point, where your hands are thawing out, but you actually think, I think I preferred it when they were frozen. I couldn't feel them so much until they, fully come back to life, if you like. Yeah. And that's the same with nerves. And it's a really, really important question that we have with our patients, because as their leg or their arm starts to become more alive, they start to think, I don't know. And you say, well, is it pain or is it activity?
Yeah.
And 9 times out of 10, people say, well, actually, it's activity.
So is this like I was thinking of a hose pipe with water and someone treading on it and
correct,
taking their foot off it, and then water coming through. So during the IDD, that sort of the distraction, and I suppose that's taking pressure off those structures, and is that then what is happening? Then that sort of increased activity in the nerve is because you've taken your proverbial foot off the nerve.
100%, because what's happening as that disc is being decompressed, we're changing the vacuum pressure in the disc.
Mm,
So as we pull on that disc material,
yeah.
and then the oscillation, the pumping effect that's going through that disc, we're changing the dynamic within the disc itself. Now, as a consequence, that disc material is effectively, it's retracting. It's slowly being drawn from the nerve. Now, another key point is that by the time you've got disc material rubbing against the nerve's becoming swollen.
Mm,
That sausage skin I mentioned, the epineurium, it's now swollen. So you can't just take a nerve off that. Take a disc off a nerve unless you cut it off. And on that note, what's interesting is when you look at the research for certainly radiating pain down the arm, and particularly the leg. I mean, surgery in the neck is considerably more risky
mm,
than lumbar spine surgery. But discectomy, microdiscectomy, that is to say, where the surgeon trims away an area of disc material, they have a 92% success rate of resolving the arm or leg pain. Now, interestingly, we follow exactly the same stats, but without surgery, without injections, and no invasion.
mm,
So,
mm,
it's just our process takes longer, whereas the surgeon goes in and you're a day case. And, if need be, they might keep you in overnight for obs and then they'll send you home.
mm,
Whereas you're going to be coming to see us for some number of weeks. But
mm,
the downsides of trimming that disc away, and surgeons are not gung ho anymore. They're very, very knowledgeable. And, where surgery might have been a little bit more dramatic in the past. Now they'll assess the disc above, they'll assess the disc below,
mm,
because once you start trimming that material away, it's going to destabilize that segment to some degree.
mm,
And surgeons talk about what they call revision, which means they might say, well, okay, we can resolve your leg pain. If you've got back pain as well, the chances are we may not improve it or may make it worse,
mm,
and you might require a revision, that is some other procedure, in the next 5 to 10 years.
mm,
So most surgeons that I speak to, or the patients that speak to the surgeons, will say, they'll say, well, if you have access to decompression treatment, IDD, try
mm,
it first. If
mm,
that fails, then come back and have a
mm,
conversation.
mm, mm. So do you see? I mean, yeah, that's obviously avoiding the risks of surgery, the cost of surgery, and obviously we're it's a full rehab program. So
Yes.
the this sort of fasciculation is something that you see with pretty much all patient, all of the patients with the nerve pain.
No, not all. Depends on the severity of the
Mm,
compression on the nerve. A lot of people don't have it,
mm,
but they may not have fasciculation. But the majority of patients will talk about, they'll use phrases like "I've got a fizzy foot,"
okay.
or a fizzy leg. Which I think is a great description, because
Mm,
I'm a very 3D kind of person, so I can
mm,
visualize what's happening within that nerve. But
mm.
we
Okay.
do see a lot of patients with fasciculation. You see it a lot in the calf muscle, actually, particularly if we're thinking, sort of L5S1 issues. Then often you can, and you can point it out to the patient. You say, if you look at your non-involved side, the calf is completely still, and you look at the involved side, and it's fasciculating.
Good.
It's
I noticed
twitching.
I
Yeah,
noticed when I started doing my rehab, because I've noticed, like, say, my right thigh, the muscle
mm.
just sort of seemed to disappear
Yeah,
very quickly.
atrophies. Yeah,
Like, I was like, oh my gosh, I thought my thigh was going to be the same width as my calf. Not that they're particularly big
yes.
anyway. But I did notice, actually, doing some leg exercises, that
Mm.
that my nerves were twitching, like,
Yes.
during the rehab.
Mm.
So in the rehab, I suppose the combination of IDD with rehab and exercise. Let's talk just a little bit about that, and
Sure,
I think we've
sure.
probably got a little bit more time.
Mm.
Do you, that as you improve as the pain is coming off and as the nerve function is improving, does that contribute as far, because you're big on rehab, as in
Hugely. Yeah.
exercise. Does that have an impact on the success of that rehab?
Yes, yes,
Or
it does. I mean, the beauty of the decompression, the IDD. I mean, I say to all our patients, it's a tool. It's a really
mm,
valuable tool. it's not the holy grail of everything.
Mm.
Although, in all honesty, for a lot of our patients, they believe it is, because they go, well, I came in, I was in agony, and now
Yeah.
I'm strolling in and I'm getting on with life. I'm doing what I want. So it
Mm.
is.
Mm.
So yeah, but what we want to do is we want to bolster around that, because you don't want to be going through this process again, because we can't make people's discs brand new, but we can
Mm.
greatly improve on the function. So it's hardly ever the case, well, it's never the case, that we don't do rehab with our patients. And
Mm.
a lot of them, we start from day one, so we get them doing things from day one. Now, and perhaps this is a subject for another
Yeah.
podcast, but for the over exercisers, we have to rein them in, and we
Yeah.
have to say, you need to allow your body healing time as well, because some people will look at IDD care and decompression as, I can come and have a treatment. Now I can just smash myself. I can do whatever I want, because
Mm.
that machine will sort it out. And,
Mm.
I've said to patients that, if you're determined to destroy your back, you will. And IDD won't, and our program won't save you. Just a sidebar on that. One thing that we've noticed, because with the progression of maintenance, when you look at the advisory protocols from the North American Medical Group, where after an intensive course of treatment, there's then a declining program of maintenance in
Mm.
terms of still bolstering that disc pump.
Mm.
Um, over the few years that we've been treating, we've had next to nobody ring us up and say, I'm back to square one. And
Mm.
on the small number of occasions where somebody's come back to us and they've been acute, the one thing that we've noticed, within 4 or 5 treatments, we've resolved their problem again.
Right.
So what that tells me is we greatly improve the health of the disc. So if somebody does do something unforeseen, they
Yeah.
respond and recover so much more quickly.
Mm.
But also the strength and conditioning. We focus really from day one on non-compressive rehabilitation. And what I mean by that is the spine's always in a neutral position. There's been a lot of conjecture about back braces. We know there's good evidence if you use an inflexible back brace, that is to say that one that supports your spine, supports your discs, but forces you to hip hinge. So you really, what it does is it retrains you to learn to bend correctly,
Mm. Mm.
So the exercise rehab is all part, because I say to patients that we have a care program, because people talk about IDD, and we get people ring us up and say, oh, hi, I see you do decompression, I see you do IDD, can you book me in this afternoon for a session? And the honest answer is no, sorry, we can't. We don't know anything about your history, you might not need it. So we're very honest with patients, say, look, this isn't, we're not sort of commoditizing, just it's not kind of chuck you on a
Yeah.
rack and give you a stretch.
Yeah.
Although a lot of our patients will say they feel like they feel like they need to be put on a rack, and you say, well, A, not surprising because of the amount of compression in your spine, and B, the good news is we've got a really scientific rack that can help you.
Yes,
You
I used
know,
to get quite upset when people say, "Oh, it's a glorified rack, isn't it?" And I'd be like, "No, it's not." And they're like, "Well, okay." Um, if you're happy calling it a rack, I'm not going to be precious about it.
no,
But it's got a bit of, yeah, a little bit more to it. Yeah, I think that echoes everything from all of the clinics about the exercise rehab. And I think that's also really important, because yes, I would exercise and I would see, actually, if I'd want to. I think when I went to see a neurosurgeon to get my MRI,
yes,
it was interesting because he reminded me that I wasn't the same physical specimen, shall we say, in inverted commas, as I was, than now, because I've had this injury,
I disagree.
and the deterioration, in that period of injury time, is dramatic, and so then you suddenly,
Yes,
so there's a kind of double whammy, that you think you should be as you were before, and so I can
yes,
still do exactly as I was before, but also you're not in the same physical condition, and that
no,
that disc um, needs more time.
yes,
So yeah, so that's interesting. So perhaps as we just sort of, I'm looking at the time. your experience then with the IDD, you've grown into it. How has that developed how's having the IDD developed your practice and yourself
Okay.
as a clinician, Lawrence?
As a clinician, daily growth, a much deeper dive into the understanding of the spine in particular,
Mm,
spinal pathology, spinal conditions. Um, the deeper dive into the understanding of medical imaging, MRI in particular. That's a numbers game. The more you see, the more you see. And I'm very
mm,
blessed. I've got some great people around me that I draw from.
mm,
We have Dr. Jeff in the US, as you know. I invest in time with him because he's he's a driving force behind this type of care.
mm,
And I have a colleague. He's a research fellow and he's a consultant orthopedic radiographer. And Lance always talks about, he says, yeah, it's a numbers game. The more you see, the more you see, and it's true,
mm.
you do. And that's a daily, weekly, monthly, lifelong discipline.
Yeah.
Um,
Does that also
oh,
help within our sort
yeah,
of WhatsApp group where people are sharing MRIs and comments on it, and
yes.
it's a sort of like a yeah a hive, if you like.
It is, and it's a hugely valuable resource, to have so
Mm,
many clinicians bringing, as you say, that hive mind or mind hive, and
mm,
and that's something that gives our patients confidence because they know they're not sat in front of one guy with a machine. It's that
mm,
we have a international group of clinicians and
mm,
practitioners that we can reach out to. So
mm,
that gives us as clinicians confidence,
yeah,
and every day is a school day.
yeah, of course.
um, and also for our patients, that they know that they're not just because there's so much faith and trust involved, especially
Mm,
when they're stepping over the threshold into a private clinic.
mm,
And then the clinic itself, well, when you look at the evolution, I mean, I have a team now, and we're continually expanding progressively, and we've just ordered our second AccuSpiner, which we're very excited about, which
mm.
obviously you're aware of.
Yes.
We have a business operations manager in Glenn, and he is a fantastic guy. He sees our vision. He sees the ethos of what we are about. And he's making daily, weekly, monthly changes for us, which is helping myself and Molly as clinicians to
Mm,
focus on what we should be doing.
yeah.
We learn patient by patient by patient, and I mean we're going to need more space. We're requiring more space. I think certainly early into 2026, I'll be coming to you to order table 3, because we're gaining more and more experience, and we more and more success stories. And as we do that, we're reaching out to our local, additional medical community. We're making GPs aware, we're making consultants aware. And that's great because we're having these conversations now, and that's very valuable because one of the things that I'm delighted about is decompression. Certainly, the AccuSpiner is it's evidence based. It's evidence based. Both anecdotally and scientifically, and that, as a clinician, again, that gives me tremendous confidence because I can be straight with my patients. I can say, look, there's plenty of evidence, and as part of your due diligence, I'm going to send you information that you can read into yourself first,
Mm,
and then you can be confident that this isn't smoke and mirrors. And one of our patients said, well, I mean, even after the extensive medical workup and the examination, the MRI, the diagnosis, he said to us later, and he's one of our success stories, he said, I'll be honest with you, Lawrence. I said, please. And we did ask him if we could paraphrase him, because he
mm.
said, well, it's gone from smoke and mirrors to miracle.
Oh wow.
I mean, how's that for a strap line?
That's it's a very nice strap line. I think some of the medical community when they see would they if they saw that strap line, they'll think, ah, yeah, here we go, you know. So I think I have a tendency almost to rein things in a little bit because if I say,
Yes, yes.
oh, it's miraculous, then it's like, come on, mate, you know, the snake
Mm.
oil, blah blah blah,
Too good
come
to be
come,
true.
too good to be true. So I'm
Yeah.
sometimes I have to I downplay, but you know, and I think that's the thing when you hear it from the horse's mouth and
Yes,
the patient is saying, you know, there's not placebo because you know, you see the patients coming into your clinic, don't you?
yes,
And then you
yes.
see them not, you know, walking out, skipping out, and you're
Absolutely.
like, just calm down. Okay, you don't need to do a marathon today. Is that that practice-based evidence for the individual clinician
Mm.
is super powerful. And then that's echoed, I suppose, by all of all of your colleagues in the network. Um,
Our
Amazing.
patients, yeah, I mean, our patients often say to us, they say, please don't take this the wrong way. When we've moved now towards either maintenance or, further down the line, discharge, they said, please don't take this the wrong way. In an ideal world, I'd never have met you.
Yeah,
But, I'm very glad I have,
yeah.
But what we want to do ultimately, this is about, we want to be that last stop for people where we go, okay, come on, let's really get to the root of this now. And when I was an undergrad, going full circle to the beginning of our conversation, it got hammered into us. No diagnosis means no prognosis, which means no treatment or management plan. If you don't have a diagnosis, don't waste people's time, and we live for diagnosis, that's what we do. And our reputation, our successes come from that, that granular diagnosis. So
Mm,
diagnosis is key, and then from that we can then offer our patients options. We're not interested in selling anything to our patients. What we want to do is put them in the driving seat of their decision making, and we draw them along with that, and we encourage them to bring a friend, a family member, a spouse, because then we can explain it to them. Because there's, as you know, Steve, this is a journey, and we talk about this, that we're on a journey with that, and without wishing to sound too sort of
yeah, yeah. Out there.
syrupy
Yeah.
out there, it is a journey, because by the time people come for disc treatment of this magnitude, it's, without wishing to frighten our patients, it's a serious spinal injury. And
Mm,
you've had one, and I've had one. We've been disabled, and thank God, we've been able. I only wish this therapy had been available when I went through the hell that I went through. But
mm,
so I think what helps our patients is we've all been there,
mm,
and we can see it in them, and we understand the emotional, psychological, financial impact. But
mm,
it's I would say to anybody that's contemplating it, if they're wavering, it's life changing on so many levels. I mean, now I have a team.
mm.
I joke that, I say, oh, great, I get Friday afternoons off now. But in actual fact, what happens is Friday afternoon, I'm thinking, how can we get to that stage? How can we scale to there? But that's
Mm.
lovely. I can be walking the dog in the woods and thinking, what can we do next? So wonderful, wonderful.
I think. I mean, I think obviously I've seen how you've progressed, and just your enthusiasm for these disc patients,
Mm,
and I think that, as you alluded to, your competitiveness from your
mm,
earlier career, combined with knowing what it was to have to be debilitated, you know, you're kind of,
mm,
yes, you're building a practice, but you're just on a, it seems to me anyway, you're on an absolute mission to help patients. So you've done an
100%.
amazing job, and I'm absolutely thrilled for you and excited for your future. So
Thank you, Steve.
I think I just want to say, you know, thank you so much for coming on today, Lawrence. And I think I'll probably have you back at some point because there's plenty more to talk about. But thank you so much.
And thank you, Steve. Honoured, absolutely honoured. Thank you for everything that you do, not only for our community of clinicians, but also for the wider community. Collectively, we're slowly ridding our community of the tyranny of severe neck and back and nerve pain. So thank you for everything you do. And if I get the opportunity, I'll be delighted to come back.
Amazing. Thank you, Lawrence.
Thank you, Steve. Have a great day.